and welcome to this edition of Practical Treatment Planning. I'm Dr. Lee Sheldon. If you like what we're doing and you want to join us some more, just push the like and subscribe button, and we'll be producing these videos every week. Today we're going to talk about a case that you encounter probably nearly every week, maybe every 2 weeks. It's a kind of case that you say, what the heck do I do? This person needs all of his teeth extracted. You can see this case and see what it looks like. Patient has not brushed his teeth in 20 years. And he said, I know I'm going to get dental implants anyway, so I'm just not going to take care of them, and now I'm ready for dental implants, except he finds out that he's not able to afford dental implants. He finds out how much they are. You know, we're a big dental implant office. Notice I'm not showing you a big dental implant all on 4 cases or those kinds of cases. Yeah, we do those every day. What do you do with a patient who can't? You just give up. So if you look at this case and you say, well, of course, we're going to extract the teeth and we're going to put in a full denture, stay with me, and you'll see how we evaluate a case and where there may be other solutions and how we can phase solutions in. And maybe the patient eventually will get everything he wants, but we can phase it in such a way that the patient may be able to afford it. Okay, so let's take a look at the case. We'll take a look first at the periodontal chart. As you know, I'm a periodontist. We'll look at the periodontal chart. Periodontal chart doesn't look too bad, does it? Patient has not brushed his teeth for 20 years. Take a look at the periodontal chart. Pockets are not 9, 10, 11. They're 4, 5, 6. Okay, let's take a look now at the radiographs. We'll take a look at the full mouth series of radiographs. And I don't want you to look necessarily at how much bone is gone. Yeah, you can see the bone is gone here. Let's take a look at how much bone is left. Okay, so we look at tooth number 2. We go across to number 6. Number 7 is getting a little bit worse. Take a look at that. 8, we've got, 1/3? Maybe a little bit more than 1/3 of the bone. Yes, there's caries here. No question about it. No periapical lesion. Let's take a look at tooth number 9, and number 9 has had endodontic treatment done. We'll look at that. Number 10, still bone support. There's still bone support here. Number 11 still had bone support. 12, 14, or maybe it's 13, and 15 still has bone support with heavy calculus. On the lower, you're not going to get a good view. He couldn't tolerate having the x-rays taken. So let's look at the CT scan. Okay, and as we go across on the CT scan, you'll notice, by the way, the right side is buccal, the left side is lingual. There is bone support there, and I'm looking for a periapical lesion. I don't see one. There's no evidence of deep caries here either. We go across now to tooth number 6. Bone support, huh? We go across to number 7. Bone support. Although there's an awful lot of mobility to tooth number 7, and you can see why. There's this wedging force, and this tooth is, 30, 40 degree angle? Okay, now we look at 8, and notice when we take our CT scans, we take our CT scans in occlusion. I know people tell you not to take them in occlusion. Take them in occlusion because you want to see that occlusal relationship. So what do you see right here? You see a crossbite. This is going to be a difficult area to restore. There is a loss of bone support here. There's on the upper, loss of bone support on the lower. This tooth is loose, and this is tooth number 25. He just lost tooth number 24 the day before. Okay, just exfoliated in his hand. And 25 is going to be lost. We take a look at tooth number 9, still bone support, huh? And there's no apical lesion on this tooth, despite the fact there's caries on this tooth. Okay, tooth number 10, still bone support. 11, lots of bone support. There's caries. How deep does the caries go? He hasn't had his teeth taken care of in 20 years. Okay, the caries goes fairly deep, but does it go to the pulp? I don't know, but we can discover that during caries removal, can't we? You know what I'm leading up to. You can already tell. Okay, 12, bone support. Not great, but bone support. 15, bone support. That bone support without taking care of himself. Okay, so let's take a look at the lower. And we can talk about how we do this for implants. As we go across here, we'll see good implant support. Here's tooth number 22. There's bone support. Yes, there's an infrabony defect right here, but there's bone support. Okay, 23. I don't know. Probably not much bone support. Probably don't want to use that. 25. No, there's not a lot of bone support there. It's loose and it's in crossbite anyway. You don't need to use that. And tooth number 26 actually does have some bone support. Does it? But it has some end-to-end occlusion. If we look at tooth number 27, bone support. Infrabony defect? Yes. bone support? Yes. Tooth number 28, bone support. That looks great. If you didn't know that he hadn't brushed his teeth and you just looked at tooth number 28, how do you feel about that? Despite the fact he hasn't taken care of his mouth, look what is happening. He still has bone support. And now we go back to tooth number 31, and as we look at that, loss of bone support, the angle is not good for the CT scan, but still it's a solid tooth in place. If we take a look at the panoramic, you'll see good bone support all the way around that tooth. So if I were to look at this and say, all right, he can't afford dental implants. So let's look at that. I'd say, all right, 2 has decent bone support, 6 has decent bone support, 7 compromised. Number 8 has caries, and that may need to be treated. Number 9, badly destroyed, but still can be treated. 10, 11, 12, or maybe that's 13. Tooth number 15. Okay, so those teeth need to come out. Is that patient better off in an upper denture? Cosmetically, he may be. Cosmetically, he may be, and that's a decision on his part. But from a functional standpoint, but he wants to function. He wants to function, and he's got this functional unit right here. He's got this functional unit right here, and maybe he has a little bit of this functional unit right here on tooth number 7 with tooth number 27. And on the other side, he has 10 and 11 functioning against tooth number 22. Tell me, is it better for us to save all of the upper teeth, or maybe nearly all of the upper teeth, and extract perhaps number 23, 25, maybe 26 because of its position, and just retain those teeth for upper and lower partial denture? You decide. Okay, if that's what he wants for function, and he has a budget that isn't enough for dental implants, are we better off cleaning him up and making partial dentures? We can do this, and we can do this predictably. What's the minimal treatment plan we're going to do in order to be able to allow this gentleman to save his teeth? Okay, first step, extract 23 and 25. Put an Essex in if you want, just to replace those lower front teeth. That makes him feel good. Number 2, oral hygiene instruction. And he has to graduate from oral hygiene instruction, okay? So that means a couple of visits. We may ask him to buy certain implements, whatever works for you, that's what we do. And he has to get through that in order to be able to qualify for the rest of the treatment. I insist on that. Okay, number 3, root planing. So we'll do root planing. We use the perioscope in order to be able to get to subgingival calculus. It's really effective. We can talk about that later on. But root planing of whatever kind, you want to clean them up and clean them up really, really well. Next, do caries control. So the way we'll do caries control is to rebuild and composite teeth numbers 8 and 9 and take care of the restoration of the facial aspect of tooth number 11. Maybe we'll do a pulp cap on that. It doesn't look like it goes to the pulp, but we'll evaluate that at that time and decide whether it's worthwhile investing in a root canal if it's necessary. It likely won't. Just do pulp protection, cover the tooth over with the composite, and likely be okay. Okay, now do a reevaluation. And the reevaluation is a full reevaluation. Full reevaluation means periodontal probing, means checking mobilities, make sure he's comfortable, make sure the occlusal stops that we've set on the teeth are really working well and he can function well on those teeth. Okay, if that works, then let's make him upper and lower removable partial dentures and let him function on that for a while and see how he does. He'll keep his natural teeth, he'll be comfortable, he'll be back into dentistry, and he can make other decisions later on if he needs to make them at all. Now, let's assume for a moment that he decides, hey, I want dental implants, but I can only afford a little bit at a time. What I want to do is create a dental implant supported prosthesis on the lower arch against a full upper denture. Why? I want to get my occlusal components right. If you take a look at the radiograph, you'll see that there's a bit of a super eruption of tooth number 13 and 15. I can't make a good lower prosthesis against those teeth on the upper. Oh yeah, I suppose I could do an occlusal adjustment, but I'm not going to have the tooth arrangement on the upper arch exactly like his tooth arrangement is right now. And what I want to do is create the ideal occlusal plane on the upper arch with a full upper denture, and then extract the lower teeth and do my lower all on, whatever you want to call it, against the appropriate occlusion. So I'm getting my occlusal components are determinants taken care of in the upper denture and in the lower full arch prosthesis. And then later on, when he can afford to do the upper, then we can do the upper implant supported prosthesis as well. It may not be bad though, because we want to make sure the patient is going to take care of it. It may not be bad for the patient to go through a trial period with his natural teeth first and make sure that he can take care of it before he invests in dental implants. That's your decision. What we want to spell out here is that, in fact, teeth can be saved. We just need to go through them one by one. And if we decide that each tooth can be saved individually and we can come up with a functional approach on both the upper and lower arches, it may be very well worthwhile for him to keep his teeth now, get used to taking care of his teeth, do well in taking care of his teeth, come back for recall after we do composite restorations on those upper front teeth, and get him looking good and get his periodontal health back. And then he can take a deep breath and then decide whether now he's ready and whether we're ready to work with him on dental implants. I'm Dr. Lee Sheldon. Thanks for joining us.